Welcome to this evening's program. We are privileged to have two expert speakers on this subject. Professor Ian Hickie, who's Executive Director of Brain and Mind Institute, Sydney Medical School, and Dr. Sebastian Rosenberg, Senior Lecturer, Brain and Mind Research Institute. Professor Hickie is a psychiatrist and he's well known. In 2012, he was appointed as one of Australia's first National Mental Health Commissioners to oversee enhanced accountability for mental health reform in Australia. Professor Hickie is a leading Australian voice on mental health issues and an internationally renowned researcher in clinical psychiatry. He is a key driver of enhanced health service delivery in this field. He has a special interest in youth mental health, in particular prevention and early intervention in anxiety and emerging mood disorders. He is in partnership with Professor Patrick McGorry. They have been at the forefront in developing and evaluating primary care-based youth mental health service called Headspace, the National Youth Mental Health Foundation.
I do want to focus very much on the youth aspects. So in terms of what's really changed since 1992 and profoundly in the last 10 years, and then in the public domain in the last 5 years, I think particularly since Pat McGorry's Australian of the Year back in 2010, is an understanding and a perception around the importance of youth mental health. The epidemiological reason is the one that Sebastian raised, is that 50% of the problems are there by age 15, and 75% by age 25. So 1 in 4 Australian teenagers will have a significant mental health problem, one that interferes with their capacity to go to school, to function, and cause risk associated with it during their adolescent years. Now, of those, half will recover and not have ongoing problems as adults, which leads to a very interesting discussion in one aspect of mental health. Well, why would we bother with that group? Because they get better. Which is not something we say if you have an asthma attack as a teenager, or you get run over by a car as a teenager, or you have an acute appendicitis. Well, you'll probably get better, so we won't bother treating you at the time. But that's one dominant attitude in the area, which explains has traditionally explained a lack of investment. Is that although there may be very serious complications of having the problem while you're a teenager, because it doesn't persist into adulthood, it's not worth actually dealing with the risks associated. On the other side of the coin, half of the people, so about 1 in 8 adult Australians, will actually have a problem that is persistent and is severe and started in their teenage years and goes on to interfere with their education, with their capacity of employment, to form families, and is then complicated typically by other social difficulties and other health difficulties, drug and alcohol problems, increased risks of cardiovascular disease, but also other social disruption. So in a wide world, there's now much greater interest, particularly driven by the OECD and other international agencies, at the productivity implications of that. If 1 in 8 young people fundamentally doesn't progress to adult life to become the most productive member of society that they should become. In 2008, the UK Government Office of Science, the UK properly organised bureaucratic system, unlike those out of Canberra, where they consider actually the science of situations, they said, what are the public policy implications? And they produced a very important paper that's worth reading, it's only 3 pages long, which is in the journal Nature, called The Mental Wealth of Nations. Not the mental health, the mental wealth. So it's written by health and science experts, clearly for bankers, right? And it shows the development of mental capital, which I love this sort of economic discourse gets over into health, right? And how you develop mental capital right through your childhood and then your adolescent and your early adult years. So the most valuable person from a mental health point of view is actually a 22-year-old. Because it takes 22 years plus an extra 9 months to get to the peak of this mental capital business. I happen to have a 22-year-old daughter at the London School of Economics who goes, oh, duh, Dad, of course I'm the most valuable person. I don't understand that. I say to her, sweetheart, that's marvellous. We've put 22 years and 9 months into your development. And she's got an average life expectancy now of about 90. You will be repaying us for the next 70 years. The social investment is the return on investment associated with that. So there's a very serious economic and social discourse going on worldwide about the need to manage teenage mental health and associated issues from a purely productionist point of view, if you like. Now, the Health and Government Office of Science doesn't take such a literal economic thing. It says actually for societies to prosper, a word I really like, to prosper, citizens have to have the maximum cognitive and behavioural emotional resources to actually do that. So it's a really serious issue. In fact, the only people in Canberra who take us seriously in these areas are Treasury and Finance. One of the people we normally think take us seriously. People in health don't take us seriously at all. They send us back to another review, another inquiry. You'll just cost us money We go, no, we're here from the banking industry. We are an investment, and we are the return on investment. But we're actually not just an economic return on investment. We actually are a social return on investment. For communities to prosper economically and social, this is government office and science out of the UK. And the most important thing you do, we don't know yet how to prevent many mental health problems. There aren't many vaccines in mental health, you know, to prevent polio. Prevention is a tough gig. We're working on it, but it's a tough gig. What we do know how to do is intervene early. If we intervene early to prevent you actually deteriorating educationally, socially, and then in your own individual development, we have the best chance of the thing. And this is the thing that Pat McGorry and his colleagues in Melbourne from the 1990s made world famous. Sort of stuff that should win Nobel Prizes but doesn't. Is a fundamentally really smart idea that you should get in early. If you're going to get in early, you get in with teenagers, because that's the period of transition. The biology post-puberty, the sociology is different, a whole lot of other risk factors. And we understand now in sort of brain development stuff, other stuff I wasted my life with in the university, about how the brain changes rapidly under multiple different genetic and environmental influences during that period. End result, it's risky from a behavioural developmental point of view. But if you get in early during that period, you have the greatest chance of making a difference, in theory. The economists, Treasury, Finance, they get it. In fact, the whole of the Headspace program really is based on a very small amount of data that Pat McGorry and his colleagues produced out of Melbourne, of showing that you could delay young people going on to the disability support pension by 50% of young people by 1 year, just by 1 year, if you intervened, okay? Really, and if you think of that in long term terms, it's really important. It's also true, not just economically, but socially. If you have a first job, if you have a first relationship, if you finish another year of school or education, no matter how bad the problem is that you have, your social and economic outcome will be better. You'll have a better life. On the National Mental Health Commission, we refer to that, not quite as elegantly as the New Zealand Commission, courtesy of Janet Marr, one of the long-term consumers in the mental health, as a contributing life. Not necessarily an economically productive life, but a contributing life. You'll be a valuable member of society. And your health status is only one of those issues, whether you've got a house, whether you've got a relationship, whether you're part of a community, whether you've got good physical health, all the other things that add up to having a contributing life, a capacity to participate. But to really achieve that, from a mental health point of view, you've got to have mental health services at the time that they matter most, which is young people. Now, of course, from a physical health point of view, except for, you know, contraception and a few other critical things, is the time when young people avoid the doctor. And young men, you do have to run them over to get them to the doctor. They're just not going there. So only 13% of young men, but actually only 31% of young women who've got a major problem. They've not seek any mental health care. And inquiries with why not, because they're actually telling the same interviewers they've got a major mental health problem, are exactly, you've got to be kidding. I'm not sitting in a GP's office, I'm not going to a mental health service, I'm not going to a hospital, I'm not going to a psychiatrist, you know, like really, fair income. You know, that cannot be what you would consider to be an appropriate service. They've got no problem about saying they've got a mental health problem, but that's not the service that's going to match, even if we think interaction with professionals or others may actually help. So what we've had in Australia is a tremendous growth in actually understanding of the opportunity. What we haven't had is turning that understanding based on this 20 years and this world-leading work out of Melbourne, which is now encapsulated in theory through the Headspace program nationally, into actually effective service delivery. I was at a World Economic Forum thing. I can see I've been hanging out with economists recently because, you know, whatever else, they have a lot of other interesting characteristics, but they're kind of rational. You know, whereas most of what we do in healthcare is irrational. We've been arguing, I was hoping that often when I've done this before, Alan Rosen turns up. You know, Alan was in the business of getting people out of psychiatric hospitals in the 1980s here in Sydney. You know, and we are still spending 85% of the national income in hospitals. In fact, in a survey we did recently, people would say that hospital care is more hospitalised than it was even 5 years ago. You know, that actually the lack of community resources has gone backwards in the last 5 years, let alone the last 40 years of actual activity. So, you know, the issues with the economy, so, you know, the World Economic Forum that I was at, a very intelligent woman said, "You're from Australia, aren't you?" I said, "Yes, nice place." She goes, "You write the best policies in the world." I said, "Oh, that's very interesting. We've been writing them for 25 years. We're good at writing policies." Because your implementation stinks. You never actually do what you say. Now, for those who know Geneva, this is across the side of the other side of the lake. On one side is the World Health Organisation, where they sit there arguing about who has the right to vote and whatever else, and something really bad happens occasionally like Ebola, and then they try to get organised, but, you know. Around the World Economic Forum side, they go, "Look, we're not interested in discussing the particular thing. We just want to know, they have examples, social ventures, other entrepreneurial, non-government organisations. What are the things that people do
to actually achieve the outcome? And how do they do that in different countries? Really interesting, different perspective. Anyway, our international reputation is we talk a lot, we go on about it. We have people in Canberra who write the most marvellous documents. We fly people from overseas to read those documents. In fact, I think the people come from overseas don't actually ever read the documents about those particular things. And I ask you every 5 years, did you do it? To which they go, well, no. No, we didn't do it. But you know, we live in a very complicated... I've got this phone here, not because I talk to Pat McGorry on the phone who's trying to ring me, but actually to show you the future, just to remind you. We actually have this set of issues about... We have a lot of excuses. Complex federated system of government, complex loss of responsibilities, you know, and what is really, really challenging, and why it's good that you take the time to engage with us this evening, is if you look at what the community thinks in Australia, we are actually world leading in community attitudes. We're world leading in writing documents. But we still stink at implementation in the particular issue. This has led, as Seb was saying kind of nicely, to those of us who are a part of this kind of social advocacy and health engagement, to a moment of pause. We seem to have got to where we wanted to get to, which is we have high-level bipartisan political agreement. Now this seems like a good thing. This could be a return to apathy. You know, if there's no contest anymore, maybe the agreement's actually to do nothing. Like it's too hard. In fact, famously, Tony Abbott, when he was the health minister, having been thrown out of his office on more than one occasion in quite a polite way. I don't think I use the exact words on the camera that he might have used. But basically the critique he had is that, you know, we do that stuff but nothing happens. And from a political point of view, that's death. Now, there's a political contest in 2010 where there was some contesting, and I must say to Julia Gillard's great credit, there was action in 2011. But still, you know, 4 years later, we're not doing it. We're actually not doing the thing. So many of us have become interested in what is the community action required to actually do that. Is it more, how many are we up to, 32 statutory inquiries? Is it more distress? I mean, I've personally been involved in several human rights inquiries, and I don't think I could personally sit through another set of hearing the same stories from the same families, from the same individuals who have endured the systems that we are talking about on an ongoing basis. I think even from my point of view, it's become a little too traumatic to hear the same stories again and to hear of no progress in a particular sort of issue. What is the set of actions to be taken? And I think across the mental health system, that's got us really challenged, because you appear to have strong community action, actually at a state level and a federal level, bipartisan support. So people like the current new Premier of New South Wales, Mike Baird, following on, whoever the other guy was who lost the Grange, Barry O'Farrell, he was strongly supportive. Following on, if we skip a few of those other Labor premiers that we'd had for only 10 minutes, but back to Morris Yema, he was very strongly supportive in the particular thing. At the federal level, actually, let's say back, discussing this week about the Gough Whitlam thing, but certainly from the Hawke through Keating period through Howard, the Rudd period was a minor problem. Back to the Gillard period and now back to the Abbott period, Rudd was the one who did not take an active interest actually in the issue. We got involved in Big Health, we did cancer care again. We hadn't already done it again and again, we did cancer care again. But Gillard, I must say now, and now Abbott, has sort of reconstructed Abbott, is actually quite interested in mental health and is very strong on youth mental health in the particular. So we've got this no problem at a political level. But we don't have action, you know, in a particular thing. So it's no longer become a political contest. It's a social contest. How do we achieve that particular change? Those of us who come, as my children remark, from the old world, those who actually knew who Gough Whitlam was and that kind of stuff, you know, we don't seem to have precipitated the actual social action to turn the aspirations of the community into real action. And that, I think, is a really open question as to what is the solution. Meantime, something else happened along the way, which is technology. So what's actually happening at the moment, I think, is a fascinating thing, and I'm part of what is called a Young and Well Cooperative Research Centre, $30 million government investment, is can you use technology? Because these guys don't live in hospitals. You know, they don't have Medicare rebates. They 24/7 do what they ever do in particular ways. And if you think, you know, Facebook was actually a technology invented by young people to connect them in various ways, to trade information in various ways. There is actually another thing going on at the moment, which we are trying to understand. I mean, we only have the tiger by the tail here. Can we use technologies in ways to connect with information? For that, 87% of young men and 70% of young women and whatever else who actually do want to connect with each other, and social connection is critical to good mental health. It's a critical aspect. That's what they're doing mostly. They're not really bullying and sexting and killing each other on the phone. They're mainly talking, you know, teenagers, they're only talking to each other and trading information and sharing connection. That's what they're mainly doing through these texts. Can we engage in that world from a mental health point of view to actually make it productive, to actually assist young people? The best examples, for example, in suicide prevention at the moment that are running throughout the country aren't being done by... He's never claimed to be a clinician. He's been organising the services. People like me have been providing the services. We usually arrive about 3 years too late to do anything in a community that currently has a suicide outbreak, etc. There's really good examples of young people doing things themselves to organise responses, you know, without any professional help in various sets of laws. We have some world leaders of this in Australia. Helen Christensen, the current director of the Blake Doctrine Institute from the ANU, Reach Out in Australia, a total community organisation out of the Keating government office, by Jack Heath and his colleagues, set up the first online suicide prevention thing in Australia in 1996 through Reach Out, etc., which now has 1.4 million unique users every year. Young people actually use the internet to connect to actually really reach sets of issues. So the really open question at the moment, and I can say this to Win and I, that we just decided we're in the same generation, of people who are from the, look, we care, you know, we're good at this.
And the golf field.
We're good. We're really good at it. However, can we take our expertise, can we take our understandings, can we take our fundamental concepts of how humans connect and promote mental health, or to the economists, mental health, and somehow do something really, really different? At least early in the phases of illness. I'm not about to suggest that all of what we need to do in mental health and mental health services can be done through a smartphone or any other set of technology. But at least where it matters, at least in the early intervention bit, at least early in the course of illness, can we engage people in such a way that is enabling, that is empowering, that actually encourages people about the advantage of having information, of having social connection, of using services in a productive kind of way. Now that is quite disruptive to the traditional health professionals. So it might surprise you that the people who hate these things the most are actually the people of my generation who get paid to not use this kind of stuff. Right? To have you come and line up in my clinic to see me, because I'm very highly trained, I'm very good to do this kind of stuff. And they get very distressed when you show the results of studies and whatever else, using this kind of stuff's about as good as actually seeing me. And it doesn't cost very much, it's 24/7, it doesn't get tired, it's not irritable, it doesn't have to fight with the kids, you know, it just does what it does.
And no waiting time.
No waiting time?
No.
You do need a national, I shouldn't be too rude about Mr. Rudd. You do need some sort of national network to connect to, but the cost and the utility becomes the really big issue, and these things are rapidly going down.
Is there a joke about out-of-pockets?
Yes. And it doesn't charge the gap, and it doesn't do anything else. It's once you get a hold, and once you develop the technology, it's cheap. It's also really interesting, it brings expertise. Okay? When you ask young people about a mental health problem, they go, what am I going to see my local GP for? What does she know about a particular problem? How expert are they in dealing with a particular problem? This sort of stuff can expert experts immediately. Not only that, one of the really good things is we're exploring this at the moment in places like Colombia and in India, and we haven't come to China yet because there's some problems about this sort of stuff in China, but in really big countries, you know, where the potential to reach out in Australia across communities. People always say in Australia, don't poor people miss out, don't Indigenous people miss out, don't the rural and remote miss out. The biggest uptake of a lot of these technologies, in fact, is in Indigenous communities. You've just got to do it differently with visual stuff rather than with written stuff. There are ways in a publicly minded society like ours, in fact, you think there's some really interesting things being done with technology with the homeless. Right? You don't have a place, but you can stay connected. If you get a Wi-Fi, free Wi-Fi for an appropriate particular issue, you can actually have much greater contact with the homeless through phones than you can in person. And they can stay connected with each other and do sorts of things. There's a whole lot of really interesting innovations happening in a particular area. So that, I think, is one of the, I'd like to say, sort of developments. Now, actually, just the second part of that is the more that people connect through technology, young people, the more when they're in persistent trouble, they are likely to then go on and use other services. Right? So I'm not suggesting it's the be-all and end-all, but it gets people engaged in a way, an empowering kind of way to go forward. In fact, the previous Minister for Mental Health, Mark Butler, who then sadly became Minister for Climate Change or something, one of those things that just went nowhere, you know, he used to, and he is considerably younger than me, he used to come to a number of public forums and he'd say, look, Ian, we're just down over there with the old people. And I'll talk to the young people about these things. Because he was saying, because he said not that the technology will get the government out of a hole that it can't get itself out of. But he did talk about something really smart, the empowering nature of being in control of your own situation, which people who are familiar with these technologies, people over at, there's this great digital divide, I can't remember what the age is, 35 or something. If you're born in the pre-digital age, you fear these things. You know, like people in the pre-digital community feared sex and feared all sorts of other things, you know. Now, if you're about 40 years, if you're certainly over 50, you sort of fear these things, you know, until you find you're 80 and you really need them again, they're really good. But younger people don't see it that way. They're enabling technologies. And you think about mental health, one of the scariest things about mental health is actually being out of control of your own situation. And technologies and services that aren't dragging you off to hospital, they're not treating you involuntarily, they allow you to engage, also feed into a very important concept in mental health, particularly for young people, they're staying in control of your own situation through certain sorts of ways. So in terms of services, to come back to Seb's essential question, if we're going to make a difference to teen mental health in the future, we've got to have a different service environment. That service environment has to be relevant to the young people of today. It has to use approaches, and I suggest technology is one, youth-orientated clinics like Headspace is another, that engage young people in a way that is useful for them on their sets of issues. And then for those who really have system problems and more severe problems, where more traditional clinical services come into play and are important, they then have a willingness to engage with those services because we've been willing to reconstruct our world to start to meet that particular need. So I, like Seb, for those who are older and requiring more traditional services, are a time of life where we are got a big question mark. We've had great aspirations, but we haven't delivered. And the big question is, what is the next social movement or social action? You know, it's no longer a political action, it's a social action. For young people, actually, I'm more optimistic that, like many good things, older people haven't dreamed up a really good solution. Young people probably come up with a better solution themselves. And the question for us is, can we take our expertise and our knowledge and combine it with technology to actually do a better job in the future? Thanks.